Good afternoon, everyone. Hi, welcome to the first webinar of our four-part series titled COVID-19 and Ombudsman Programs, Understanding How Trauma Impacts You, Residents, and Your Advocacy. The focus of today's presentation is person-centered trauma-informed care. The other webinars in this series will be held once a month, so please save the dates for 3 Eastern Time on May 20th, June 17th, and July 29th. Since you are already registered and here with us today for this webinar, you are registered for the entire series. So there's no need to register again, but please share this with your colleagues, your volunteer representatives, and so on, so we can have even more folks the next webinar in this series. My name is Amity Overall-Labe, and I'm with NORC. Before I introduce our speakers, I do want to say thank you for all that you are doing in response to this pandemic. This situation is impacting everyone immensely on both professional and personal levels, and there are still so many unknowns. Thanks for advocating for those that are the most vulnerable in this crisis, and for figuring out creative ways for individual and systems advocacy despite in-person visit restrictions and constantly evolving guidance and information. We developed this series hoping that it will provide you with a better understanding of how trauma impacts you and those you serve, as well as give you some tips for taking care of yourself during this extremely stressful time. Our speakers today are Leah McMahon, she's the Colorado State Ombudsman, and Dr. Sherry Gibson. Dr. Gibson received her PhD in clinical psychology with an emphasis in geropsychology from the University of Colorado Springs, UCCS. She's an instructor and clinical supervisor for the psychology department at UCCS and a faculty affiliate with the Gerontology Center. Dr. Gibson serves on the editorial board for the Journal of Elder Abuse and Neglect and is a member of the research committee for the National Adult Protective Services Association, or NAPSA. She's also a member of the Pikes Peak Elder Abuse Coalition. She's been recognized for her trainings on person-centered and trauma-informed care approaches with older adults among professional programs such as APS, Area Agencies on Aging, long-term care facilities, and community outreach veteran services. And I know that she's done a lot of work with the Colorado Ombudsman program, and that was how we were introduced to her. So I paused just for a moment to make sure that you all could hear me because I seem to have lost some fuzziness on my line. So just to let you know, we are experiencing some technical difficulties. Our main presenter lost internet connection at her office, so she is en route to her home to join the webinar that way. And so we are going to go through a couple more slides and speak with Leah, and if we need to reorder some of our presentation, then we will do that. So just wanted to give you a heads up that we are working at our current internet situation, as I know a lot of people are experiencing technical difficulties because of the system overload. All right, next slide, Katie. Thank you. So just so you know, if you're not familiar with Zoom, but I feel like the entire world is now, all attendees are muted today, and you can ask questions by using either the chat box or the Q&A feature on your screen. So you get there by holding your mouse and scrolling it down your screen, and you'll see a little bar pop up. And you can use the Q&A icon or the chat box, whichever one you choose. Feel free to enter your question or comment at any time during the presentation. However, we won't get to those questions until the presentation is complete. And yes, a webinar recording and materials will be posted on our website, and we'll send a link to that information to all webinar registrants once they're available. And yes, I see in the chat box asking for a link to the slides, and we will do that as soon as we can. Thank you very much. So, Leah, as I mentioned earlier, she is the State Ombudsman for Colorado, and her program are the very generous sponsors for this webinar series. We are extremely grateful that due to their support, this training is available to Ombudsman programs across the country. So thank you, Leah. And I'd like to turn the webinar over to you so you can say a few words.
Okay, great, thanks. Can you hear me?
I can, thank you.
Okay, great. Yes, as Amity said, I am the State Long-Term Care Ombudsman for Colorado. I have been an ombudsman prior to that for about 9 years, and I took on this role in October 2019. I am super excited about this training and just wanted to make a few remarks before we get started. Our country has seen this pandemic take many lives throughout long-term care. It has impacted people throughout our country and the world, and we are struggling with how to cope with grief and loss and manage our daily work lives in a different way than ever before. This training series by Dr. Gibson is timely for ombudsmen to be reminded of person-centered care and trauma-informed care, something I think everyone can relate to in our professional as well as our personal lives. I find that working with my team here in Colorado and in my role during the pandemic has been very challenging, in that we have at times been reactive and have really struggled with being proactive. In being reactive, we are at risk of losing sight of a variety of things, including person-centeredness. So this is our opportunity to hit the pause button, take a moment, take a step back, and remind ourselves of what is most important. So let's enjoy this training and get the best out of it that we can, take this opportunity in this time. And with that, I'd like to welcome Dr. Gibson.
This is Amity again. Thank you, Leah. And I apologize to everyone for the audio. I know it was a little crackly, but thanks for hanging in there with us. So just one moment. I see that Dr. Gibson is available on the phone line. Hi, Sherry. Can you say hi so I can just make sure that I can hear you?
Hi, Amity, and hello, everybody.
Great. Hi.
Hi.
You sound pretty good right now. If you're on a cell phone, I will pop on if we're having issues hearing you to just give you a heads up. But glad to have you here today, and we'll go ahead and go to your slide, and we'll keep the poll where we originally planned it, Katie, now that she's on the line. So thank you very much. Welcome. Oh, there's the poll right there. Never mind. Sorry about that. All
Okay.
right. Glad to have you.
Thank you. And I see that my, do you have video of me? I mean, do you have the video on me? I think we were going to have that also available so that people could see me, or no?
Yes, but until you're in front of are you in front of your computer, or are you just on the phone line?
No, I'm in front of my computer. I'm actually set up. Yes.
Okay, great. So if you click on the panelist link and join the webinar on the computer, then you can hit the start video icon that's on the bottom of the screen.
Okay.
And thank you again all for bearing with us just a little bit. I think everyone's gone through similar things during this pandemic, unfortunately, with the strain on the internet.
Sorry, I thought that I was on the panelist, and it's saying that I can't start the video. So I probably clicked on something different.
Okay, let me see here. Let me try to find you in the attendees line. What's your cell phone number? Are you listed on?
719-339-2862.
719. Okay, there you are. Let me see if I can. Nope, I cannot.
Okay, hold on.
Okay.
Let me leave the meeting.
All right, I think she left the meeting just for a moment. So while we are figuring that out on her end, Katie, sorry to bother you again and make you change the process again, but can you go ahead and post the poll? Everyone, we just wanted to know who all is with us today. So we want to know if you are a state ombudsman, if you are a representative of the Ombudsman program, and you'll notice that one column is for paid positions and the other is for volunteers. So please self-identify. And if you choose other, just to let you know, there's no option on the poll to actually write in the other, but you can submit that in the post-webinar evaluation because we would like to know who else was able to join us today. So thank you.
Okay.
Great. So it looks like we have a lot of representatives, both paid and volunteers. Excellent. Hi, is that you, Sherry?
Yeah, it is me.
Great. I went ahead and launched the poll since we were just figuring out some technology. So,
Oh, thank you.
yeah, no problem. Were you able to join on the computer too? On the panelist side?
I am on the computer, but I'm not able to find the panelist side. I'm sorry. I don't know where it is.
Okay.
So I'm not
Well,
sure.
it was the email that was sent to you. It was the link that says click this link. So it doesn't say panelist specific, but can you just touch your screen and do you see a little icon on the bottom left-hand side that says start video?
Okay, hold on.
And if not, we can just, if it's okay, could we just go ahead without video this time and then we can figure it out for the next
Yeah,
webinar?
I guess so. It's not allowing me to start the video. It says that
Okay.
I can't because
All right. So
the
just,
host has stopped it, it says.
okay. We
Okay,
will
that's
work on
fine.
that on our end. But just so you know, the attendees on the call, the majority are paid staff representatives of the office. We have some state ombudsmen as well, and then we also have some volunteer representatives of the ombudsman program. So thank you all for being here, and I'm going to go ahead and stop sharing the poll results, and
Okay.
we'll launch into your slides. Thank you, Dr. Gibson.
Okay, you're so welcome. Thank you, everybody. I see there are quite a number of people on the call, and I am just very grateful to be here with all of you today. I was thinking on the way here, maybe a poll question that I should have put on here is, where are all of you in your house or in your space right now? I wonder how many of you are in your pajamas or with an animal on your lap or a small child. I actually had to rush here because the internet went down in my office. So I am now calling you from my home. I want to thank National Consumer Voice and the long-term ombudsman of my state of Colorado for this collaborative effort to bring you a training that I believe is very important and also very timely during this time. As Leah stated at the beginning, this is an opportunity for us, at least in today's training, to hit that pause button and think about person-centered and trauma-informed care, which is, for those of you who are, the majority of you who are on this call who are ombudsman or work within the ombudsman program, and I would assume other people who work in advocacy, you're probably well versed in person-centered care, and yet in a time of crisis, in a time where we are making decisions constantly against a changing landscape of care, and responding to a lot of different crises at the individual level, up to the organization level, our community, and a global level. This is a time to remind ourselves of these very basic things. So I'll ask that whoever's helping with slides to change the slide now. So the intent of this training for you, and it is going to be a bit of a speed dating process, unfortunately, because we're getting a little bit of a late start. So the good news is that the slides will be shared, so you will have a lot of information at your fingertips as a resource. But my intent of this training is to really share what I know about the field of person-centered and trauma-informed care approach and person-centered thinking, really, based on my experiences of both working in long-term care as a psychologist, also in private practice. I was also the director of Rocky Mountain PACE, the program of all-inclusive care for the elderly in the Behavioral Health Services Department. And so I come to you with my own experience clinically and working in long-term care and with ombudsman and adult protective service caseworkers. And then also this opportunity today to explore what person-centeredness really means and how do we appreciate the individual experiences of trauma and what that has at the individual level for people and what we can do in order to resist the re-traumatization of the persons we serve. And to identify, and I hope that while you're observing this and listening in on this webinar, that you are identifying those particular situations or persons with whom you've worked where you could have done a better job, where things got in the way of person-centered thinking, or identifying where your strengths are and what your successes have been. I also hope at the end of this presentation that we have some time to answer some of your questions, but most importantly, it is really to remind each and every one of us what is at the center of all the work that we do, and that is the person. The person is at the center. We can think about the person as the person who is coming for services, but I also want to remind you that the person is us, and the person is also our coworkers, our peers, our colleagues. That is also the person. Slide change, please. So across the globe and across our nation, a large number of cases have been reported. Thousands of people have died, hundreds of thousands have been affected. But no matter the number, each person is an individual, which reinforces this need for person-centered thinking or person-centered care. Slide change. Change the slide, please. Thank you. For those of you who might, I'm going to take you way back to either your undergraduate studies or graduate studies. A lot of you might be familiar with Carl Rogers, and Carl Rogers was really the grandfather of person-centered therapy. He believed that empathy was the core of therapeutic change with people. What does empathy mean? Empathy means that we can connect very closely with another person's experience. And in that connection, we have a real desire to help. Now, does that mean we can fix whatever the problem is? No. But we have a desire to help and to relieve the suffering of another. Clients to Carl Rogers are viewed through this lens of potential, that we see people for their potential and for what they can be, even when they can't see what that potential is, where they cannot see in that moment where their strengths are, that we see that at all times. And that as therapists and as people who are helping, that we exhibit to those persons a very positive and non-judgmental stance, that we meet them truly where they are in their current situation. Slide change. So what is person-centered thinking? How do we define that? Just as Carl Rogers always identified, it's really supporting the person where they are rather than dictating or fixing. I would assume that many of you have been in a situation where you have been talking to a person, telling them what your challenge is or where your problems are in that moment. And you've probably been with somebody who immediately steps in to want to fix the problem. And you know, as the person who is trying to talk about your problem, that's usually not very helpful, unless we've asked specifically for some help. But typically, people really need that space to talk and to feel supported, not to actually experience from the other a fixing or a dictating of telling what they should do. Person-centered thinking at its very core is a strength-based approach, that we're building off the strengths of the person. One of the things that I love about working in geriatrics, and I'm trained only in geriatrics, and that is my private practice, is that working with older adults means that they have a whole lifetime of experiences and drawn upon wisdom for which they can address whatever is bothering them in this current moment. So I will often ask my clients, what were your strengths going through a really difficult time in your past that could get you through this difficult time? And part of that process is really understanding that person's personal story, their personal experience, and listening to it. When I teach clinical skills to first-year graduate students, we talk about the power differential. Power differential is always there the minute that you walk into the room, because just by your professional role in and of itself, you own the power in that relationship. The one way that we can balance power in relationships is that we have to stop talking and let the other person start talking. Now, I know this gets tricky for those of us who are very task-oriented in our professional duties, where we have to do assessments and we've got to get a lot of information. But giving a person just 2 to 5 minutes of quiet time to tell you their story has an amazing impact in terms of their own healing process, but also in terms of the information that you can get to help be a better steward of their care. Person-centeredness is really building a culture of partnership, learning, keeping people accountable to what it is that they want to do and what they want to achieve. And it's an approach so that we can discover that meaningful information that is used later to create these person-centered plans, care plans. When we get that rich information from the conversations that we have with our clients, that helps direct and helps guide our interventions and our recommendations based on what their values and preferences are. It also aims to promote individual choice, autonomy, their own control of their life and the supports that they receive. And it helps ensure that people really do have positive control over what that desired life. Now, their desired life might be very different from our desired life. And person-centeredness means that we take our values and our preferences out of the equation, and we let the person guide us and generate those ideas. Because as most of you probably know, that when the person generates their own ideas, when they come up with their own solutions, they are more likely to be successful at obtaining and being successful at the outcome. Slide change. I think it's also important for us to look at person-centered care at the individual level, but also understand how this affects the culture of our organization. So you want to look at person-centeredness and think about ways that you can reframe language. For example, when I've worked with adult protective service caseworkers, we have a lot of discussions about the way we even document our notes in electronic health record systems, or the way that you all do documentation. And we've talked about the importance of using the person's name when we can in our documentation, rather than referring to them as patient or as client or resident, referring to family members as their roles and their names, rather than, for example, pathologizing people, offender, or sexual offender, abuser, those types of things. There are ways that we can reframe our language, even at the documentation level, which trickles down to the way we see our clients. But in the way that we talk about people also, even behind closed doors with one another, can shape the way that we interact with our clients or residents for Ombudsman. So I'm going to really hone in on that a little bit when we talk about trauma-informed care. It's also important that we honor what's important to people so that we can balance what's important for them. So that's a kind of a tricky concept, right? Because knowing what's important to an individual, for example, I worked with a woman who had developmental disabilities, and she really enjoyed arts and crafts. And she lived in a group home, and her caregiver, that person's responsibility was to make sure that she had enough money and to take her to her favorite craft store. For those of you out there who might know Michael's. Michael's was her favorite craft store. And so he knew that that was very important to her. And so he would take her on a weekend. And one of the things that she loved to do was to go through each and every aisle, painstakingly going through every article. But she always had a craft project in mind. So usually at the end of their shopping, before she checked out, she would typically have a very large basket full of things. And so the caregiver would say, okay, I understand that you have $42 and you've got a large basket of things. What do you think we need to do? And she would say, well, I guess I need to put some things back. I need to get rid of some things. And he would help her go through each item and help her make decisions about if that item was for the craft project that she was really interested in, or was it something that she could get at a later time. That takes a lot of time and energy. But what he knew about her was that she could do that process, and he also understood his role in it, that also our own limits and what we do as providers needs to be very defined. So for example, if he didn't want to take the time, he might just give her, say, okay, you're $20 over, I'll just give you the $20. And at your next payment from that you get next month, you can just pay me back. Well, what's the risk of that? The risk is that it's important for her to learn how to budget. It's important for her to learn that she can only do what is in the parameters of the money that she has while satisfying what's really important to her. If he were to give her that $20, which would save a lot of time and a lot of effort, she would not learn that lesson, and he would be setting up a new rule, which is, I will cover whatever you want in the future. And so this is how we have to balance that all the time with the people we serve. We also have to listen to how they want to live and support people in making use of the resources that are available to them in order to live the life that is most desirable. And finally, we want to provide that support to assist people with making those things happen. Slide change. There are 5 foundational beliefs in the literature about person-centeredness. And the important questions that we always want to ask is, who is that person and what is important to them? When I work with caregiving families, there's not, well, quite often is the case that different adult children will have a value or have a preference for how their adult, their parent should be cared for example. And there's a lot of decisions that have to be made, and sometimes the adult has the capacity to make that decision, and sometimes they don't have the capacity. When the person doesn't have the capacity, oftentimes adult children will come in with their different views about what care should be. And one of the things that I ask families all the time is, what do they understand that their parents' value is? And once the family can establish what the parents' value is, then every intervention that we create or every treatment plan involves that value and is in line with that value. So if mom's value was to stay in her home and die in her home, then we don't have a conversation right at the moment about transferring her to long-term care. We might have a conversation about palliative or hospice care. And so when we can come together on that shared value, then we can really be effective in the types of interventions that we recommend. Person-centeredness also fundamentally challenges the practices that separate people and perpetuate those controlling relationships. We want to bring people together rather than making it an us and them. We also want to respect the dignity and the completeness of the whole person. I was trained in a biopsychosocial, spiritual type of framework, and that's how I see clients. I see them for the whole person, and whatever may rise to their level of concern in that moment is what we attend to. But we have to know the whole person, and so that we can be effective in helping. Also, another foundational belief is that we assist people to define and pursue desirable future that both test that person's clarity and commitment and courage. Okay, slide change. So with that in mind, that kind of foundation of person-centered care, I want to then transition into trauma-informed care. And if we were in a room together, I would be asking you, how do you know when person-centered care is working, and how do you know when it's not working? And you will likely identify that when it is working, people are engaged. People are letting you know that they are satisfied with the outcome, or letting you know that the suggestions that you're helping them come to, or the ones that you're making, or the resources that you're providing are in line with what their desires are. When it's not working is when people fire us, when they close the door on us, when they stop taking our calls. That's how we know that somehow we're not aligned. So trauma-informed care, SAMHSA, which is the Substance Abuse Mental Health Services Administration at the federal level, has done a lot of work around trauma-informed care and trauma-informed approaches. And the three main things that they have added to the literature is, one, that behavioral health is essential to overall health of an individual, that prevention works, and that treatment for trauma is also very effective. And we'll talk about all of those things. Slide change. The main elements of trauma-informed care that you need to know is that first we have to recognize or understand the prevalence of trauma. We then have to recognize how trauma impacts individuals at that very individual level, and that's going to be a very diverse and subjective experience. And that then we need to put that knowledge into practice so that we actively resist re-traumatization. Let me give you an example of what this might look like. When I was working at PACE, I had a client who was in her late 60s, and she had a very troubling history, a childhood abuse history. And I knew about her childhood abuse, but I didn't know all the specifics of it. And I'd been working with her for about a year, actually, when something happened. She came to session one day and she was sobbing uncontrollably. And one thing about this client you should know is that she had a diagnosis of bipolar disorder. And way back in the day, in the 70s, she'd been given a diagnosis of schizophrenia, which a lot of people got early, 30, 40 years ago, when we really didn't have a good understanding of bipolar disorder. You had a lot of people who were misdiagnosed with schizophrenia. So she'd had several diagnoses over her lifetime. She'd been hospitalized in inpatient psych hospitals a number of times throughout her adolescence and adult life. One thing about her was that she was very motivated in therapy, and yet trust was slow to gain and happened over a long period of time of meeting with her on a weekly basis. So she came to session one day and she was sobbing uncontrollably. And I knew that she had recently started to show a decline in her medical conditions. She started to become incontinent. And so at PACE, there are two types of incontinence briefs that are out there. One is the type that you pull up like an underwear, and the other type fastens at the side, which is very similar to a diaper. And in fact, you will hear people refer to incontinence briefs as adult diapers. Well, she had been getting the pull-up kind, and apparently our nursing department, home care services department, had an overstock of the type of incontinence briefs that fastened at the side. We had sent those type to her home, and immediately she was triggered into her childhood trauma. So much so that she She hid all the knives in her house to ensure that she wouldn't hurt herself. Because as an adolescent, she had used cutting as a way to numb herself from the pain. When I finally got her to settle in the session, she told me what had happened. And she told me that getting the type of what she called diapers had triggered a memory of when she was a child and was abused by her family that involved feces. So I asked her, without disclosing her trauma, if I could advocate for her with our home care staff in order to get the other type of incontinence briefs delivered, and she agreed. And I was able to do that, and she was better. And this example to me really epitomizes how we might miss something, such a benign action of providing that type of incontinence brief triggered such a deep-rooted childhood abuse history to the point that unraveled this person. And what it also highlighted for me is that how many people had we inadvertently re-traumatized that didn't have a counselor to tell that to, that didn't have somebody that they could disclose it with, but yet had to deal with it despite the trauma and in order to maintain their incontinence health. So this is just one example that I share with you, and I want you to be thinking about in the care of your residents or clients, what things do you do that might actively re-traumatize somebody. And working with Adult Protective Services, the one thing that they do that is part of their practice is the unannounced visit. So they have to do that, right? They have to show up because they need to know that person, what is happening in that moment in that person's home. And unfortunately, that also traumatizes people when somebody with that kind of power, which they certainly assume, that when they show up at their door. Slide change. Mental health has really done a very good job of pathologizing behavior. We have an entire manual on it, a diagnostic manual, the Diagnostical Statistical Manual 5, version 5 right now. And we identify symptoms, behaviors as symptoms. And so what we want to do is the underlying question shouldn't be what is wrong with you, but what happened to you. And that symptoms aren't viewed as maladaptive or pathologized behaviors, but that these are adaptations to traumatic events, and that healing happens in relationship. Slide change. And speaking of relationship, I just want to say that for those of you who aren't therapists, we can all be therapeutic in our relationship. So I just wanted to highlight that too. So what do we know about trauma? First of all, trauma as a definition, individual trauma that is, results from an event or a series of events or a set of circumstances that is experienced by an individual as either physically or emotionally harmful or is life-threatening. And that experience has lasting adverse effects on the individual's functioning, on their mental, physical, social, emotional, or spiritual well-being. The identification of a broad range of that potential effects reminds us that our response must be holistic. It's not enough to just focus on the symptoms or the behaviors, but our goal is to support an adult or any person to learn and to grow and to live a satisfying life. Slide change. I've listed here the different types of trauma or traumatic events. And the first and second list is fairly intuitive to most of us, but I want to spend just a moment talking about the third column, and that is chronic stressors. We often do not think about the context of some of these chronic stressors, such as poverty and racism and invasive medical procedures. So this might be the woman who always planned to have her own children and then was forced to have a hysterectomy for a medical reason, or the person who lost a limb because of maybe uncontrolled diabetes. Community trauma. In my own state of Colorado and in my own community, we had a really catastrophic fire about 8 years ago that wiped out hundreds of homes, displaced hundreds of families. And that was a community trauma that happened here that also had reverberating effects to individuals. Historical trauma, such as Holocaust, genocide, Native American trauma, slavery, clearly. Those types of traumas also have an impact. And then living with a family member with substance abuse, and I would also add mental illness. It's also particularly important for me to emphasize here that many people experience multiple traumatic experiences over the lifespan. While the immediate focus when we're dealing with our clients or residents might be on just a recent event, particularly now during COVID, we might be dealing with that recent trauma. The individual's reaction to that event is likely affected by an earlier experience. And that couldn't be more relevant to where we are right now in this period of time. Slide change. The prevalence of trauma and exposure to trauma is ubiquitous. What we know is that 7 out of 10 respondents worldwide on a study by Fink and Galea in 2015, and 9 out of 10 adults in the US reported experiencing 1 or more lifetime traumas. So trauma can be cumulative. Slide change. Just want to give you a few statistics so that you can understand the prevalence of trauma at another level. So 13% of children in the US will experience a confirmed case of abuse or neglect by the age of 18. And we know that that number is largely misrepresented, right? Misrepresented because a lot of cases go underreported or unreported and then unsubstantiated. 3.5 up to 10 million people witness violence against their mother every year. 1 in 4 girls and 1 in 6 boys are sexually abused before adulthood. Slide change. 84% of adult mental health clients have a history of trauma, and 50% of female and a quarter of male clients have experienced sexual assault in adulthood. Slide change. Up to 65% of all clients, not surprising, that are in substance abuse treatment report childhood abuse, and up to 75% of women in substance abuse treatment report trauma histories. Slide change. 92%, and I think that this statistic is staggering, homeless mothers have severe trauma histories, and they also have twice the rate of drug and alcohol dependence as those without. Almost a third of all veterans seeking treatment for a substance use disorder also have a comorbid diagnosis of post-traumatic stress disorder. Slide change. So given that we understand the prevalence of trauma, we need to then understand how trauma impacts the individual. Slide change. This next slide has a lot of verbiage on it, and you don't need to really pay attention to all this, but I want to point out that the CDC, in conjunction with Kaiser Permanente, did a really large study where they looked at 17,000 insured individuals between the time period of 1995 to 1997 and asked people what types of experiences, adverse childhood experiences they had prior to the age of 18. Slide change. And what they found was that these were the types of experiences that people endorsed in that survey. It included physical, sexual, emotional abuse, physical neglect, emotional neglect, mother treated violently, household substance use, mental illness, parental separation or divorce, or having an incarcerated household member. And this information then, for a lot of you probably might have worked in child protective services and may work with families now, might use the ACE measure, so the Adverse Childhood Experience measure, and it asks people to indicate if they had any number of these types of experiences before the age of 18. Because what we know is that the short and long-term outcomes of those kinds of childhood exposures include a multitude of health and social problems. So as the number of ACE scores increases, or ACEs, if you will, increases, the risk for the type of health problems, which I'll show in the next slide, if you'll just move, or actually I might have changed that. Actually, go ahead and move one slide up and we'll go back to this one. There you go. So as the number of ACE increases, the type of health problems increases with a strong and graded fashion. And with that, there's a direct and negative impact on mortality and longevity. So you can see here, these are just some of, it's not an exhaustive list, but some of the main health consequences when people have ACE scores that are, that increase over 7, for example. So you've got illicit drug use, a liver disease, smoking, sexually transmitted disease, risk for sexual violence, poor academic achievement. I want to go to the previous slide if we can go back. And this is some interesting statistics just to really highlight the impact that childhood trauma has on adult behavior or behaviors in adulthood. So persons with zero ACEs, 1 in 16 smoke, that goes up to 1 in 6 with 7 or more. 1 in 69 have alcohol problems, where 1 in 6 are diagnosed with alcohol problems. 1 in 480 uses IV drugs, goes up to 1 in 30. 1 in 14 has heart disease, 1 in 6 with 7 or more ACEs. And this last one is really meaningful to me. 1 in 96 attempt suicide, and with 7 or more adverse childhood experiences, 1 in 5 attempt suicide. One of the things that we have to also address when we talk about childhood trauma specifically is that trauma has an impact on the brain. And if we could see each other, what I would do is I would hold up my fist and I would show you that at the wrist, if you were to look at your fist in front of you and kind of, I don't know, I don't even know how to explain what I'm doing, so forget it. I will just tell you that that's what a PhD will get you. It'll get you to look at your fist as a brain. But your brain is organized in a bottom-top fashion, meaning that the first thing that develops is your brainstem, which is responsible for your breathing, your respiratory function, your heartbeat. And then it progresses to your occipital lobe, which has to do with gait, to your temporal midbrain, which is your memory consolidation, your limbic system, your emotion center, and then finally your frontal lobes, which is the last to develop. So what we know about brain development and trauma is that there is an organic biological nature at which our brains do develop. But as all of you know, there's a nature-nurture interaction. So the environment also plays a big role in how our brains develop. When there is a trauma that interrupts that course of normal brain development, it also interrupts, it activates that amygdala, which is kind of your fear center. It shuts down the frontal lobes of your cortex, which is involved in decision-making, impulsivity, being able to multitask, and it derails that healthy development and interferes with normal functioning. The next slide depicts this a little better in showing that at the very bottom of this schematic, you have adverse childhood experience that might be happening at early brain development. And then at that top area, you've got the more complex functions when we think about brain development. Here you see that when there is a trauma, it disrupts that neurodevelopment. It then leads to social, emotional, and cognitive deficits that then also leads into health risk behaviors, adoption of those health risk behaviors that leads to disease, disability, problems in our social context, and in some cases, early death. Okay. The effect of trauma at that individual level, what we need to understand that to be is that it's conceptualized as a normal response to an abnormal situation. That people will do certain behaviors in order to avoid the pain and the suffering that is caused by a traumatic event or the perception of that experience. 3 concepts that most of you are familiar with is the fight, flight, or freeze concept. And that has been used at the biological level to understand how our sympathetic nervous system reacts when we are confronted with a threat. What I'd like for you to consider in this particular training is that we're going to use those concepts to describe the behavior that we might see in the persons that we're serving. So some common behaviors are these that are listed. And we can see the fight response, for example, in the mental health system. Someone who struggles too hard to hold on to personal power may be labeled as non-compliant or combative. On the second, we have the flight response. And again, in the mental health system, anyone who is emotionally withdrawn or disengages too much might be labeled as resistant or uncooperative. And then third is the freeze response. I kind of call this the bobblehead phenomenon. This is where people who give in too easily to authority and therefore may be labeled as passive or unmotivated. Many of the people we serve have survived circumstances that we can hardly imagine. What we often label as pathological may be the very things that help them survive. So when we take that trauma-informed approach, we recognize that symptoms, or I'm using quotations here, problem behaviors, as adaptations to trauma frequently include feelings of helplessness and loss of control that trauma often causes. So I want you to be thinking about situations in which a person might have responded to you in these ways. And if you can reframe that for yourself, to then ask the question, what is it about this situation that they're feeling threatened? And I've asked a person that, what feels unsafe about this situation? I'm getting a sense that you're not feeling safe, or that this situation isn't safe. Can you please tell me what's going on with you? And oftentimes, if we just acknowledge that there's some fear there, the person will tell us what's going on with them. And then we can change our own behavior or change the environment in order to make them more comfortable and to elicit engagement. Okay, next slide. Trauma has both short and long-term effects. It affects every part of a person, their ability to cope, their relationships over time, and developmental tasks. When you go back to that slide where, and I don't need you to go back to this slide, but where we talk about the interruption in normal neurocognitive development, people might have trouble concentrating or attending, and that's going to cause a person to not remember things or not be able to follow through with tasks. And trauma can impact the physiological responses, their well-being, their social relationships, their spiritual beliefs, their ability to work or to stay employed. So again, this is a physical, spiritual, behavioral, emotional impact. And what we want to know in our person-centeredness approach is really understanding the whole person so that we can understand how that trauma might have affected them. Now, I'm going to ask a really important question here, which of course I can't get your answer, but I guess what I want to say here is that we don't have to know all the trauma of the clients that we see. We just need to know that when we see certain behaviors that look like a traumatic or a trauma-related response, that's where we can ask and become curious. And during this time of COVID, I think this becomes an even more important task for us, is that when people respond in ways that may not seem logical to us, that may not seem rational, and that may be the residents themselves, that for those of you working in long-term care, that may be the family, that may be staff or administrators, people in the business office. You have to ask yourself, now that you know the prevalence of trauma, we approach every situation with the assumption that somebody has experienced or has witnessed trauma. When we approach every situation and every person in that way, then we can react in a way that can be healing and that can be positive. Next slide. Other factors that affect the impact of trauma is that most trauma occurred early in a person's life, that shame and humiliation are core features of a trauma experience for many people. Those emotions can be devastating and they can impede healing. And one of the most important messages you can ever give a trauma survivor is that no matter what happened, it wasn't their fault in any way. Sometimes trauma survivors are intimidated by their perpetrators into not telling what happened. And other times when they do try to talk about what happened to them, they're ignored or disbelieved. So one of the important things that you can do for trauma survivors is give them the chance to tell their stories. Healing starts when a person's personal experience is heard and is validated by us. The impact of trauma is even magnified more when the perpetrator is a trusted figure, either a relative, it could be a religious leader, a coach, a teacher, or even a therapist. This kind of trauma is often called betrayal trauma, because the sense of betrayal can be so profound to that individual. Next slide. So now we have to put it into practice, don't we? And I know that I'm coming up on time. So we'll spend the next kind of 5 minutes talking about the practice of trauma-informed care. So now that we have to fully integrate that knowledge that I talked about earlier here, to put into our policies, our procedures, and our practices, and always seeking to actively resist the re-traumatization of our clients. It's also important on the next slide to make the distinction between trauma-informed care and trauma-specific care. Trauma-informed care is what I've been talking about this whole time. But trauma-specific treatment is evidence-based treatment that is used to facilitate recovery from trauma. It directly addresses the impact of trauma on an individual's life and helps in the recovery. That kind of treatment is designed to treat the actual consequences of trauma. And I would just encourage each of you on the call that you know that you have available at your fingertips a counselor or a therapist, a psychologist, or even an agency who specializes in trauma, so that when this does come up with your client, you can give them a resource. You don't have to be the healer in that case. You can be therapeutic, and by being therapeutic is connecting people with other resources so that they can get the help they deserve. Okay, next slide. There are 6 core principles to trauma-informed care. These principles were developed to inform a change process. And it was developed by a group of national experts, including trauma survivors, with an extensive public input. The goal was to establish a common language and a framework for all of us working in the helping services or helping fields. And it's a values-based approach. It's a way of being, not a checklist or technique. And I think if that's the one thing I'd want to impart to you, it is that we don't clock in and at the beginning of our day and become person-centered or trauma-informed. It is a philosophy that we all adapt, that we live with, that we breathe with. It is the way that we move about our world, whether or not it's in the checkout line at the grocery store, or it's in the nursing home, or it's on the phone with a client or a distressed family member, or in educating an administrator, or even on our own calls as we are collaborating using these various technological methods of communication. We use this as a philosophy. And those 6 principles are understanding, safety, trustworthiness and transparency, choice, collaboration and mutuality, and impairment. And what I'm going to do is, because we are really coming down to time, I want to move, if we could, quickly to slide, I'm going to just move us all through this, to slide 44. Because all of you can certainly read these slides, and I wish I had more time to go through them because they're all pretty important. So if you go to slide 44, it should be a Venn diagram. Keep going. It's at the very end of this. There we are. So what we have here is, in the center is the relationship. And on the periphery is us understanding the prevalence and impact of trauma, promoting safety, earning the trust of the people we serve, embracing diversity, knowing that trauma is experienced at the individual level, and what might be traumatic for one person may not be for the other person. So we can't assume that people who went through the same trauma will have that same experience. Providing holistic care and understanding the psychological, physiological, social, and spiritual impacts of trauma on the whole person. Respecting human rights and pursuing that person's strengths, their choice, and their autonomy. Sharing power in the relationship, and communicating with compassion. Next slide. This next part is on skill development. And I think what we'll do here, because we are, again, I'm supposed to be quitting like any moment. I might want to weave some of this into the next training that I'll be doing, which I think might be on compassion fatigue, because what we are encouraged to do as practitioners and helpers, as advocates, is that we can't ask people to do anything that we're not willing to do. And so this part of the training is really focused on our own skill development, holding up the mirror to ourselves to become better at understanding our own responses to trauma, because all of us on this call, I'm assuming, are having a reaction to the global, to the local, to the national trauma we are being inundated with images in the media of death, of at a magnitude that none of us have ever experienced. And that has real implications. I know that there are likely people on this call that are in the frontline trenches in places that, you know, people are calling the hot spots of our country. And for those that aren't in the hot spot, just being heightened to the anxiety of residents and families and direct care staff. So understanding our own trauma reactions right now is vital, because that is going to come across in the way that we provide care. I hear from a lot of people this feeling of, from some, feeling of apathy, feeling of helplessness or ineptness in what we do as helpers, because there's so little we can do. And especially, I know in my state, the ombudsmen are not allowed to go, are not going into facilities, and that might be happening in many states, and not being able to put eyes on in the way that we are most helpful, in the way that we are most impactful, is very distressing for a lot of people. So we'll have to skip through this part, but I think we'll be weaving some of this in. I want to go, if the person who's helping with the slide change, I want you to go to the end of this section. I don't know if you can even see the slide numbers, probably not, I'm guessing. There's a picture of a hummingbird, and I'm going to end with that. So that, because I really want to, I see that there's probably a lot of questions coming through, so I want to be able to address some questions. I want to share with you a parable about the hummingbird. And this was a painting done by a very dear friend of mine, because I use this parable a lot in the lectures that I give or presentations. I want you to imagine a jungle that's on fire. And on the periphery of the fire stand the large jungle animals. You have the elephant and the giraffe and the gorilla, and they're crying and sobbing at the devastation in front of them. They're saying things like, how can our homes be burning down? I've lost families in this fire, and they are just devastated by what's happening in front of them and feeling so helpless because there's nothing they can do to put out this fire. And the elephant, the great elephant, notices a small hummingbird that is flying overhead of them, going over to the fire and dropping little beaklets of water onto the fire. And when they follow the hummingbird, they see that the hummingbird is going to a pond behind them, sipping up little bits of water and flying over to the fire and dumping these little beaklets, droplets of water on top of this huge raging fire. And the elephant says, hummingbird, what are you doing? You're not making any difference in this fire. You're not doing anything to help this fire. And the hummingbird stops and she says, I'm doing all that I can. So I want to impart that to all of you as we take this pause, that in this moment of watching the fire burn, of sitting in front of a crisis that is beyond our wildest imagination, the devastation and the death, that for every little action we do, we're doing everything we can do. And to give anything less than that would be unethical for many of us. And sometimes it is all we can do. If we can be that listening ear to the resident or to a staff member, to a family member, to a neighbor, I want you to be the hummingbird. I want you to think about the little ways that you do everything that you can in order to improve a moment, whatever moment that is. Maybe the moment is for yourself. Maybe the moment is for a client. Maybe the moment is for a family member or a neighbor. But just doing what you can, because we're not going to solve this problem with, I wish there was a magic wand. I'm sure we all wish there was. We're not going to solve this quickly. And yet we can still do what little each of us can do. So I want to thank you for this time. And I'd like to go ahead and open up for questions or comments. I've definitely given you here a bibliography for additional reading that I recommend. Probably one of the greatest reads in trauma is how the Body Keeps the Score. And I recommend that to anybody. The first half of the book is a little dense, but the second half of the book is very practical and applied. So again, I just want to thank all of you and open this up for some comments or questions.
Thank you, Dr. Gibson. Wow, what a beautiful way to wrap up your presentation. Lots of helpful points and great information. And I'm glad we have that recorded, because I may have to figure out how to edit just that part about the parable and have it available for people to replay for themselves during this difficult time. So I want to reassure everyone, yes, we had tons of chat comments coming in, several questions. We obviously are not going to get to all of them today, but I do want to reassure you that this is part one of a 4-part series, and we are going to adapt over this series the presentation slightly in order to respond to your needs. And so we will be compiling these questions, working with Dr. Gibson, and figuring out our next steps. And so just want to reassure you. And we do know that she didn't have time to get through all her slides. And again, I apologize for the technical issues at the beginning, but thank you for being patient with us. So with that, her slides will be available, and I'm sure she'll want to touch on some of those in future presentations. So a couple quick questions, and if you have time today and want to spend extra time on the phone with us, please do, because I want to get through at least a couple questions, and then I have a few slides to share with you with some resources. One question, and I know you touched on it briefly, but wanted to see if you wanted to give any last comments to any points that individuals can use to help avoid triggering other people based on whatever trauma they've experienced in their past. So just general tips in communicating and being in relationship with others.
Well, that's a big one, isn't it? I think being aware of the reactions that we get from people. For example, I mean, it's very basic, almost basic clinical skills that we can all use. So being attentive, what I notice is nonverbal communication makes up 80% of our communication. We know that from the literature. And so I'm very aware of nonverbal communication. But that, I will say something about, since most of us are having to talk to our clients on the phone right now, or maybe on a Zoom call, if we're lucky enough to have video, I'm becoming even more aware of the nonverbals that come across on a phone call. When there are long pauses of silence, when a person, their intonation, their tone, their inflection in their language changes, I ask about it. When I notice somebody, if I get to be with them face to face or on a Zoom, and I notice that they respond nonverbally to me, I don't brush over it. I ask about it, and I will just simply say something like, "I noticed that your eyebrows went up, or you furrowed your brow, or I noticed you changed positions, or it looks like I might have said something that didn't resonate for you. Can you tell me what's going on?" If a person starts crying, I might say, "Can you put words to your tears right now?" I think that attending to nonverbal communication is one of the ways that I use a great skill just to connect in the moment. Because if we know that healing really does happen in relationship, then we want to be in that moment with the person. I also notice that if I'm talking too much, then I'm not allowing that person to share. So just be mindful if you're taking up the airtime, because it might be a good place for you to pause and say, "Look, I've done a lot of talking. I'm going to shut up. Let me hear from you. What are you experiencing right now?" So those are ways to be in the moment with a person. When you get into more of like, what can we do at the organizational level or our documentation, that's kind of another conversation that might be, I probably don't have time for that as well. But I think just being in the moment and being aware of the other person and how they're reacting to you cues you in to what's going on with them, and you can ask about that. And if you are the kind of person that avoids that kind of thing, because there are avoiders among us that don't like to confront, you can always go back. You've not lost anything. You can go back the next time and say, "I've been thinking about our conversation, and I picked up on something that didn't feel good or felt off. Were you feeling that too? And let's talk about that." Take a moment to explore that. so we can always go back.
Thank you so much. And again, you have quite a way with words. I loved putting words to your tears. Very well said. And I agree, there's a lot of things you can pick up without seeing each other these days. And yes, we will have video for the next webinar for those that asked. And the webinar recording will be available. And yes, if you registered today for this webinar, you will be for the whole series. So all these questions are really big questions, but maybe this will be a shorter one. Do traumatic events always necessitate pathological symptoms, or can some individuals have emotional resilience to come out of such events transformed or maybe impacted differently?
Yes. Oh my gosh, yes. Yeah, there is something to be said about resilience and resiliency. And I would say, yes, this is where, you know, not one size fits all. There's a lot of literature about what makes a person more resilient than another person. And a lot of it has to do with perspective, what meaning people take from a traumatic experience. My own father-in-law, who's now deceased, did 7 tours of Vietnam as a Huey gunner. And he came back from that experience in a well-adjusted way. But I have worked with veterans. In my internship, I worked at the VA Palo Alto and worked a lot with Vietnam vets, particularly, who were not transformed in a positive way, but that were, you know, crushed by the experience. And I think it has to do with the meaning that people make from the experience and what they do with that and the perspective that they take from the experience. And so when we can help our clients make meaning, when I work with people who have a religious faith, for example, or a spiritual faith, I will ask them, what does your spiritual faith or your religious faith tell you about forgiveness? What does it tell you about hopelessness, or other big existential questions that come up when people are trying to make meaning? Because oftentimes when people have gone through something very traumatic, they will say things like, where is God now? God has abandoned me. And it's in those moments that we can ask people, what do you think the meaning of this? What does God, as you understand God, have in store for you? It's not putting the silver lining around the trauma, but trying to understand the perspective and maybe writing a different narrative that is a little more softer around the edges.
Thank you, Dr. Gibson. And not only a new narrative, I would imagine that would help individuals have some agency and control to define their own story, which is obviously very important right now when everything seems very out of control.
Absolutely.
So I hate to do this, but I am going to close down questions for now. Again, we have a record of all of these, and we'll do our best to follow up either individually or weave them into future presentations. So Katie, if you can go to the first resource slide with the links, please. Thank you. So wanted to leave you all, if you haven't seen these web pages yet, with some links to COVID-specific information, as well as our trauma-informed care fact sheet and trauma-informed care issue page. And Consumer Voice, the agency that operates the Resource Center, has a page on COVID too that is more specific to family members, consumers, and advocates. Next slide. Thank you. So I wanted to let you know that we are on the very, very final steps of before posting and sharing a new resource specifically for Ombudsman programs, talking about taking care of you. It will review compassion fatigue, burnout, individual trauma, and trauma-informed care, share some typical reactions to stress, as well as some self-care tips, and some program management considerations, because not only are many of you worried about taking care of yourself professionally and personally and your family, there are also oftentimes people that report to you as employees or volunteers. And so we tried to incorporate some bigger picture considerations for you all to think about related to trauma and taking care of all of those in your network as best you can. Next slide. So during today's webinar, Dr. Gibson discussed person-centered trauma-informed care during COVID to help lay the foundation for future presentations. Again, I know we didn't get to all of your questions today, and Dr. Gibson has a wealth of information to share, and so we'll do our best to incorporate those in the future. In future webinars for this series, she will discuss compassion fatigue, vicarious trauma, and other issues related to how you, residents, and your advocacy may be impacted by trauma during this pandemic. So if you have specific questions that you didn't submit today or requests for information as we go through the months of these trainings, please email me directly or at the Resource Center email on this slide. And like I said, we'll work with Dr. Gibson on doing our best to incorporate those needs. I don't know about you, but for me, some personal takeaways I just wanted to reiterate that will really stick with me is that trauma-informed care and person-centered care is really a way of thinking and a way to approach relationships and communication with everyone. Although we are not all therapists, we can be therapeutic in our relationships. And last but not least, reminding yourself to hold up the mirror to yourself as we're all having a reaction during this time of our shared, very traumatic experience during this pandemic. So those are definitely some of the many takeaways that I have personally. Last slide. So before closing out, again, wanted to say thank you so much, Dr. Gibson, for this presentation, and to Leah and the Colorado Ombudsman Program for making this available to everybody. Thank you, Katie, for managing the back end of the webinar today. And as I mentioned earlier, we really appreciate your patience with technical glitches. That's just the way of the world these days with the bandwidth on the internet. So thanks for your patience. We'll do our best to sort them out in the next webinar, including video of Dr. Gibson. Thank you for your daily advocacy and work with and on behalf of long-term care residents. Your work is especially challenging during this pandemic, so please, please, make sure to take care of yourself. We hope you found today's webinar helpful and that you'll continue to tune in for the rest of the series for additional tips and information for yourself, your program, and those you serve. Please take a few minutes to complete the evaluation that will pop up after we close out this webinar. Your feedback is very important to us as we shape this series. So thank you again for being here with us today, and hang in there. Take care.
Thank you.
Bye.